This is the, I'm going to get out of the way, the doctor panel to have an opportunity, if you're either virtual or in person, to ask questions of our three panelists. We have, you've met Dr. Jack Langer already from Toronto Sick Kids Hospital, Pediatric Surgery, Baddr Shakhsheer, Pediatric Surgery here at St. Louis Children's, and Shannon Joerger, PDGI here at St. Louis Children's. So go ahead.
About a 4-year-old who has frequent soiling and doesn't want to wipe herself, and the stools being loose, and wanting to know what to do with that. And I think that that goes back to Dr. Langer's presentation, which is you have to know what the underlying cause is. I think frequently the not wanting to wipe themselves is usually discomfort in the area, or a rash in the area, or usually skin breakdown in the area when it's related to diarrhea. And so we enlist the help of our patient educators, which are most frequently our nurses and nurse practitioners, because they really do a lot of the patient education. We try to get barrier creams on there. We try to break that cycle early. We have actually had some experience with really bad diaper dermatitis using steroid creams, which has been encouraged by dermatology if the barriers don't work. I don't know how often you guys have used that for bad diaper dermatitis.
Some, you know,
Yeah.
I mean, it's a trial and error. You know, the skin management is trial and error, and there's so many different products available. You know, wiping is often painful, but you know, it's kind of squirting water on it, and there are products for that. It will clean it up and with much less pain. And then as far as the underlying cause of this kind of diarrhea problem, you'd need to know a lot more information. You need to know, is this a total colonic Hirschsprung's? Is this a short segment Hirschsprung's? Is this a problem with hypermotility? Or is this a problem with hypomotility and overflow? And then there's investigations that I talked about in my talk that help us figure out the underlying cause, and then we can intervene based on what the underlying cause is. The REACH website also has a frequently asked questions section, and it does cover the question of barrier ointments and ways to handle severe diaper rash, and that can be helpful. Does anybody have any other questions? I wanted to ask the panel about it's a GI question. There's a lot of motility testing that you can do. You can measure how the anal rectum work and how the colon works. And sometimes it's not clear who should get that testing and when it's useful. When you have a patient who's having an issue after a pull-through operation, when is it appropriate to do that kind of testing? Specifically those two, the colonic motility, which isn't offered at a lot of places, but more commonly the anorectal manometry. As we heard from Jack, every kid with Hirschsprung's doesn't have that rectoanal inhibitory reflex. Their sphincter just doesn't relax properly. But when is it useful, and how do you decide on which patient should get it?
Yeah, I think in particular, patients who are struggling with incontinence issues, when you've kind of done some of the other workup to see if there's a huge stool burden, do we think this is, you know, related to overflow or not? If it doesn't seem related to overflow, then kind of being able to assess that sphincter and what the tone is, and a patient's ability to squeeze then, and are they able to really increase pressures? I think that's one area that's really helpful for. I think also those who are really having significant issues with constipation, and some of our typical things aren't helping, kind of knowing if the defecation dynamics are normal. Are they able to, relax the sphincter appropriately, the external sphincter, and really let stool out, and are they able to bear down? I think that's when that can be really helpful. I think colonic manometry is probably when some of almost all the other evaluations for what's, causing either more obstructive symptoms or incontinence symptoms have kind of not really shown a reason. I think then looking to see, if there's a lot of constipation still, like just assessing more of whatever is left of the colon, what's the motility of that. And I didn't go into colonic manometry much earlier, but that test is a much more involved test than anal rectal manometry. So anal rectal manometry is an outpatient procedure that doesn't take very long, about 15 minutes or so. But a colonic manometry is a very involved test that involves a clean out the day before, usually as anesthesia for a colonoscopy to place this long catheter throughout the colon, and then a period of wake up, and then, doing the motility testing, which then can take several hours. So it's a multi-day process. So usually would not be a first step in evaluation. But so that could help in showing, is there, lack of response of that colon to stimulus that's given, which may be a meal or maybe like bisacodyl or a stimulant laxative, to see how that colon's moving for patients who are having, ongoing kind of obstructive symptoms, or those who have the, incontinence, if there's this sort of hypermotility where, just kind of watching that and, not have that slowdown at the end. And is that what's really going on? I think can be helpful.
I'll just comment also, because there are many places that don't have colonic manometry. But there are a couple of other tests that can be done as screening tests if you don't have access to the high tech stuff. And one of those is what's called a SITS marker study or a shape study, which has been around for 50 years, where the child swallows these little shapes that show up on X-ray. And then you just do a bunch of X-rays over time and follow them through the intestinal tract. And if they get to the bottom and sit in the rectum in a normal period of time, like in 24 hours, then it suggests that the colon is actually working fine. And then there's another study that's a nuclear medicine study that's similar, where you give the child some milk to drink with this marker in it, and the nuclear medicine camera can then follow it. And we prefer that in Toronto because it's a little bit more quantitative, like you can actually measure the percentage that's in each part of the colon over time. And again, if it all ends up in the rectum in 24 hours, then probably the colon is working okay. If it doesn't, if it's kind of spread out through the colon over a day or two, suggests that there is an abnormality. And then if you want to really understand the details of that abnormality, then you have to get the colonic manometry. But and then the child should be referred to a center that does have the colonic manometry.
I think the age factors in as well. I think the age of the patient and when they're having trouble factors in as to these manometric studies, because often I will, again, depending on the presentation, so this is an overgeneralization, but if you're going to be there to do an EUA anyway, I will often place Botox into the internal sphincter if I think that's high enough on my differential as the cause. And with Hirschsprung's, it's almost always high enough differential as cause, because you may treat the problem and obviate the need for the invasive testing, or the child who is too young to undergo the invasive testing. So.
Yeah, that's a good approach. We do the same when I have a kid who has obstructive symptoms. We'll sort of do this workup. First, you do a quick anorectal manometry, get them to sleep, do an exam under anesthesia, sigmoidoscopy, make sure there's no twist in the pull through or some other problem, and Botox empirically to see how they do, and get it all done and go home. There is another question in the chat that talks about crying and screaming during the act of stooling. And this is specifically in a toddler age patient, that the patient is stooling normally, but crying and screaming, and the potential causes of that.
Well, there's a number of different reasons that can be happening. I think probably the most common is if they've got skin breakdown around the anus and it's painful when the stool comes out. So that you have to examine the child and see if there's any skin breakdown, and that you deal with the same way we were talking about before. There are some children who have spasm of their sphincter as well. They haven't, especially in the kind of toddler age group where they're going through the potty training process, and they haven't quite figured out how to relax their sphincter properly. So they may be contracting the sphincter or experiencing some spasm of the sphincter, which they'll perceive as painful while they're passing their stool. So I think anorectal manometry is sometimes helpful to sort that one out if it can be done. But the problem with that age group, especially a child who's crying while they're pooping, there's no way they're going to accept the manometry catheter in there. And sometimes I found that Botox, if all I have is a child who's crying incessantly during defecation and there's no other reason like skin breakdown, sometimes I'll just try some Botox and see if that helps, and sometimes it does.
The only other thing I look for is a fissure, especially if there's a history of stool and the blood in the stool or blood on top of the stool. It's a good story for that. Although usually you don't get diarrhea with that. Usually you get stool withholding behavior associated.
Chris.
Yeah, this is more of a comment than it is a question. Going back to the 4-year-old who didn't want to wipe,
I also like to add that it could be a psychological or emotional situation. Benjamin, even at 9, sometimes he still wants us to do it. And I think it's more of an emotional support. If he's really not feeling well, if his stomach is really upset, or he had a, more of a complicated or painful stool, he wants us to do it. But I think it's more of emotional support of us being there to kind of help him with it than it is really an issue. So I just wanted to remind the parent that that could be it as well.
Yeah, that's amazing. And that's the huge benefit of these groups. I think that's also the huge benefit of these multidisciplinary centers. And, I always joke with Dr. Joerger, and I joke with the rest of my team, is that I never see patients without them, because I think always surgically, right? And I don't want to overtreat a problem. That's exactly what you just said. It's really the benefit of our association with the Rankin Jordan folks, is they really have a comprehensive evaluation that involves a psychologist as well. And they drill down on the actual answer to these problems. So thank you for mentioning that.
I wanted to follow up on that because I think it's a really important comment. A lot of children who grow up with anorectal surgery, whether it's imperfect anus or Hirschsprung disease, and if surgery in that area, dilations, irrigations, it does lead to withholding behavior and the decision at some age to say, I'm never going to stool again. So there's a push in the bowel management world to rely a lot on rectal enemas. And I've always found that to be counterproductive because it exacerbates this whole problem that you're talking about. So I'm curious how you each feel about the role of rectal enemas and how you approach it.
Yeah, I mean, I tend to avoid rectal enemas, especially in the Hirschsprung's population. And anorectal malformation is a different story because they just don't have the physiological continence, and you have to rely on enemas. But in Hirschsprung's, I really try to avoid it a lot. There was a pediatric GI guy in Columbia in Missouri, whose name David somebody I forget, and he wrote a lot about this and taught me the concept of anal defensiveness. He would say that this child is anally defensive, and anytime you go anywhere near his bottom, he's going to withhold. So I think if you can get away with stimulant laxatives and which accomplish essentially the same thing, perhaps not as effectively, but people are afraid to use stimulant laxatives sometimes. There's this fear that they're going to get used to it. Their colon is going to get lazy. And I find the pharmacists perpetuate that myth a lot. Oh, you can't use that in a 3-year-old child. Senna, ooh, that's terrible. And you can't use it for a week and that's it. You can't use it after that. So I think we have a big job to do to try and reverse that, because I think, and you can go up to big doses of Senna or bisacodyl if you need to. To me, that's better than the rectal enemas.
I agree with that. I think use enemas as sort of last resort if we're really not able to get the oral medicines in and increasing doses of stimulants or just vomiting or something. I mean, to the point where it really need to have a big impaction, but otherwise I try to avoid them.
The only time I really think that the enemas actually help is when there's true pelvic dyssynergy in a patient who's otherwise recalcitrant, and you're breaking through that with the enemas and providing some rectal stimulation. But short of that situation, which you can treat multiple different other ways, including Botox, I think that rectal enemas at best are a pathway to try to get off of that situation, not a treatment plan. And in the chat is just a reach out to you that says, thank you to the gentleman. I do believe that is what is with my granddaughter. So kudos to you. You can have the 4th seat. I'll just go back.
Related to the medication, what advice would you give on how to explain to a parent the medication journey to a parent who is reluctant to have their child on medications and just can't wrap their mind around, well, my kid already stools 15 times a day. Why would I give him laxatives or stimulant? What is your best advice on how to explain that to a medication reluctant parent?
I'll take a first shot at that. So first of all, you have to be sure that the medication the child is on is the appropriate medication. So child who's stooling multiple times per day, because they've got a giant rectum full of stool and it's just coming out a little bit at a time, that's one thing. But if they've got hypermotility and they're stooling multiple times a day, they need the opposite. They need to slow things down, different medication. But the way I try and approach it is that this child has a problem, that a medical problem that requires this medication for him or her to live a normal life. If you had a diabetic child who needed insulin, you wouldn't think twice about putting that child on insulin because that's what that child needs. And this is no different. This child needs this particular medication for this particular reason, and that's going to give him the best quality of life possible. And when you use I find using the insulin diabetes parallel, it resonates with people because everybody understands diabetes and insulin.
When I have a family with a newly diagnosed child with Hirschsprung disease, very often they ask, is my next kid going to have Hirschsprung disease? And so the question of genetic testing comes up. And I know that there is not a fixed answer to this, but I'm curious how each of you approach that. Do you do genetic testing on every child? Are you selective? Do you never do it?
So I would say genetic testing without the guidance of a genetic counselor is not any part of my practice. I think that there are consequences to genetic testing that are beyond the scope of my practice that really should be guided by a specialist in the field, because there are psychological consequences to knowing that there's an underlying genetic cause that are very, very important. There are historical elements that they key in on, and frankly, with respect to the syndromes, they keep up on the literature probably better than the average surgeon does. With that qualification, I know that we were talking about a paper that's coming out, but there's no consensus guidelines. So I generally have not tested unless specifically requested by the family, or there's such a long family history or obvious history or comorbid other conditions that we know run with certain genetic causes, then I will certainly make the referral to genetics. And we're fortunate to have a great genetics group, but short of that, I have not gone to routine genetic testing yet.
Yeah, I mean, I agree with that. Doing genetic testing for everybody, I think, is wrong or unnecessary. But there are certain specific situations. If there is a family history, then I think it's reasonable to do genetic testing. Although finding a mutation in a parent and an uncle, and then finding that same mutation in a fetus doesn't mean that fetus is going to have Hirschsprung disease. So you have to be really careful. And the counseling that has to go along with the genetic testing. So again, I would not order genetic testing. I would do a referral to clinical genetics and let them do it. So if there's a family history, number two, if there's some kind of syndrome that's been identified, other congenital anomalies or other findings that would indicate some kind of syndrome, then I think it's a good idea to do genetic testing. And sometimes the parents just request it. They want, and in that case, I send them to the clinical genetics people. And sometimes they end up getting testing, sometimes they don't.
Yeah, I agree with both of you. What you were referring to, Jack, is the fact that Hirschsprung disease has this very complex genetic inheritance pattern, and say that the penetrance is very variable, highly variable. So we even have mice that are genetically identical, and the mother will have, a bunch of pups with Hirschsprung disease. We know because they're white, because the same cells that make the nerves in the gut make the melanocytes in the skin. And yet some will have really long, like one baby will have long aganglionosis, another one will have short, and another one just lives forever and has no problem. It doesn't have a bad colon at all. So that variable penetrance is an issue, I think, for genetic testing, because they'll have the baby has a mutation. You're like, but we can't tell you if they're going to have Hirschsprung disease or not. Syndromically, I think it is important. You can diagnose things like Undine's curse, or with certain mutations. So it can be informative. Does anybody have any other questions?
Kind of going with that, just to confirm. So finding out a gene mutation doesn't necessarily help treatment unless, like, if you already know your child has a syndrome, is that right? Is there a benefit to find out a gene mutation to help treatment is my question.
For Hirschsprung disease, no, it won't change the treatment. We still same operations, same post-operative management. There are mutations that can cause something like Shaw-Wardenberg syndrome, which is associated with Hirschsprung disease, can be associated with congenital deafness. And so maybe that can guide treatment, or this other congenital central hypoventilation, Hirschsprung disease, and breath holding at night can guide the pulmonary side of treatment. But otherwise, everybody with Hirschsprung disease probably has a mutation in the RET gene. That's interesting, but for right now, not really helpful.
I'd say for obviously the diagnosis of trisomy 21 generally is diagnosed before this or during the whole process. And so for trisomy 21, certainly there's lots of screening tests that are generally accepted in terms of regular thyroid function tests, regular white counts to screen for leukemia and things like that. Short of that, we don't really have long-term monitoring plans for the other genetic issues associated, unless I'm missing something.
No, but Jack mentioned earlier, the Hirschsprung disease research collaborative. This is one of the goals of the whole research community in Hirschsprung, is to make this correlation between the mutation and the risk of mostly enterocolitis, or the risk that they'll have fecal soiling later. If we can ever link it that way, that would be really helpful to people. So far, it hasn't happened, but the work's just starting.
I think one of the questions you asked the parent panel was about, tips for parents, most important takeaways. You've seen hundreds of patients, maybe thousands collectively. What are the gems that you can offer the audience that have been the most impactful?
I'll start with one. I think teaching parents from day one what enterocolitis is, making sure they realize that, what the symptoms are, knowing how to do an irrigation, because they can do an irrigation and then call the doctor. I think that's been that's an important part, I think, of the education of a new diagnosed family.
Yeah, I think that I agree with that, and learning irrigations has been life-saving for many children. I think just being your child's advocate, and then when they get old enough, teaching them to advocate for themselves. We were talking about that last night, and you guys were talking about during the panel. I think that's crucial. And trusting your instincts as a parent. I mean, I always teach the residents that I always say mom, but it should be parent knows their child better than you do, and you have to take seriously any concern raised by a parent. And then I guess the last thing is, with the move in North America towards multidisciplinary teams and centers of excellence in colorectal surgery, I think if your child does not have a smooth course and there are problems, then don't be afraid to ask for another opinion from a place that has a lot of experience. And if your surgeon or other caregivers are hesitant to provide that referral for a second opinion, then you have to worry about that provider. Like anybody worth their salt is going to be keen to help you get another opinion. So that would be my advice.
I think, kind of, as we've said before too, things tend to get better with time, and kind of that's good, for most patients, but also I think just recognizing as we've kind of come up with, there's a lot we don't know necessarily about what causes certain things to happen or what causes certain things to get better. And really, you guys teach us a lot too, because there's a lot of trial and error involved, and some things we just have to try. When we talk about diet and stuff, some of these things we don't have the answers for a lot of it, because it's sort of you guys can tell us almost more than we could tell you what might be helpful.
Yeah, just say, we learn a great deal from parents. This because Eric's participated in a lot of medical and scientific meetings. We have a community of maybe roughly 200 scientists around the world who study Hirschsprung disease. We've put together this group at the Pediatric Surgery of North America group, maybe 50 to 60 surgeons who are very committed to taking care of kids with Hirschsprungs. And that entire community talks to each other. So when I get a case that I don't really know what's best for them, I'll call Jack or usually Jack. Jack gets a lot of phone calls from around the world. So that's what I think is very important to recognize first, that there's a lot of people who care a great deal about making this disease better and making kids better who have it, especially, as we look toward the future. but also that your doctor needs to, your surgeon really should be fully committed to phoning a friend when they don't know what to do. That puts me many times in an awkward position. I'm curious how you handle this. A family will reach out by email, often through the Reach email, and everybody should feel comfortable emailing that when you have a question. We usually will just direct you to someone we know in your area who can help answer it. But then they reach out and they're like, they're not going to travel all the way to Boston or Toronto or St. Louis. And so the question is, how do you handle it? I have offered many times to talk to their doctor, but I feel uncomfortable making that phone call. So I say, give them my email and have them contact me. Probably 80% of the time, they do not do that. I don't know if they're no time or embarrassed to ask a question. So I'm curious, how do you help people remotely who can't travel? And honestly, it's very hard to give an opinion by email. You have no idea. You need to see the kid.
Well, I do what you have said is I try and find somebody in there who is local for them, who I know knows about Hirschsprung disease and has experience, and refer to them. If there isn't anybody, then I just like you, I say, have your doctor, have your surgeon call me. And they call sometimes. Most of the time they don't. But there's a limit to what we can do, right? And there have been times where rather than having the child come to Toronto, I offered to go to where that child is, because I like to travel and I like to help people to do these more complicated operations. And it's better for the child because they get to stay where they are. It's better for their surgeon and their center because they actually learn something. Sending it to me or sending it to another colorectal center is not going to help them the next time this problem comes up. So I've committed myself to trying to go, and obviously I can't always do that. And sometimes they don't want me to come, or they don't want anybody to come. And so we haven't been able to help everybody who needs help, I guess is what I'm saying. But the best we can do is offer support and offer referrals to people who know what they're doing.
That's where the sort of network of surgeons who are focused on it, the writing consensus statements or guidelines for the whole community. Hopefully the whole goal of Reach and the E part, it's educating not just families, but even educating pediatric surgeons, and that can be helpful. Is there anything you guys think we should mention?
I don't think so, but I always appreciate learning from the families. I love these meetings. And I also put in a plug for the, between these conferences, Reach does put on these coffee and conversation sessions where we bring in an expert on a particular topic. I think the last one was a psychologist from your place, and that was absolutely superb. So the person gives a short talk, and then there's lots of questions and answers, and it's all online, so you don't have to go anywhere for it. So keep your eye out for those, because I learn a lot from those, and I think they're great for the patients too.
I believe this whole seminar will be posted online and available, and I think at reachhd.org you can actually watch previous year's symposiums. There's educational videos on how to perform dilations and irrigations. There's these coffee sessions are all on there. It's as Liz said, we try to be very sort of rigorous and as much evidence-based as possible. So we consider it a very reliable source of information, and you can always reach out with questions. There is a very receptive crew ready to help in any way we can, as much as we can. Well, thank you very much for this.
And I think with that, we'll say until next time and next place. Thank you so much again to our hosts here. It's been fun, educational, and moving. Until next time, bye now.